To answer a question like, why does kids' health matter, seems almost ridiculous. Of course it matters. Not only are children human beings, they are also our future. We have to set our children up to succeed because they're the ones that are going to be in charge of the planet one day. I don't think there's any amount of effort we could put in that would be too great for an issue of this significance. If you want to make the next generation healthier, lead by example. Get outside, play with your kids, talk to your children like they understand the things you say, because they do. When you explain to children how being healthy manifests in their lives, when it comes to things that they care about, give them a little credit. Have honest dialogues with them about, hey, the things that you're so excited about, the athletes you admire so much, the musicians, the actors that you aspire to be like, they eat these healthier kinds of foods, and this is what allows them to play basketball in the way that they do, or sing on stage and dance for 3 hours at a time. They will take that ball and run with it, literally and figuratively.
Please welcome to the stage Irvington High School student athlete Andrew Smith.
Good afternoon, everyone. It's an honor to be here today. First, I want to thank my athletic director, Dan Sanacor, and Vicki Crawford and Jessica Lawrence for giving me this opportunity today. My name is Andrew Smith. I was a victim of childhood obesity. When I was 4 years old, my weight gain really started to happen. I was eating unhealthy foods and drinking vast amounts of candy and sugary drinks. To both me and my family, at this age, it really wasn't a problem. But when I became 10 and 11 years of age, it became to notice that it was a big deal. I continued overeating and wasn't curious of what I was eating. When I turned 14, I started playing sports. I played football as a freshman in high school and ran track. I was a very active kid. People around me didn't understand why I was so big and overweight. I was, and still to this day, a very dedicated athlete. I worked on my craft every day of the week. By my junior year in high school, I was 280 pounds. At this time in my life, football became extremely important to me. Going into my junior season, I was fighting for a starting spot on the varsity football team, which I received. This is my first year playing varsity football. Being a big guy, my coach, Coach Pete, didn't think twice about putting me on the offensive line. I weighed 300 pounds, and my eating habits was terrible. This affected my performance on the field. Around December of my junior year is when my life started to change. One day, I was walking in the halls at my school, and I ran into my coach. He said, "Drew, if you lose 20 pounds, you'll be a much better player." He gave me a challenge. He said, "I want you to lose 20 pounds by the season starts." I said, "Coach, I got you." For that Christmas this year, I asked my parents for a scale. January rolled around, and I got to work. I set a goal for myself to lose 50 pounds. I purchased a gym membership at a local gym in my town. The first month was the same results I always got, which was eating the wrong foods and still gaining weight. That was because my diet hadn't changed. I was still eating unhealthy. February of 2013 is when I started to experience change. I was working my tail off and eating healthy foods and drinking water. I would train so hard some weeks that I would lose multiple pounds. Growing up in an urban area, it was hard to continue to eat healthy. It was a corner store on every street with cheap and unhealthy foods, which was very tempting. I was continuously motivated to stay on the right track by the help of my family, friends, and coaches. April of 2013, I reached my goal. I went from 300 pounds to 250 pounds. By this time, eating right came natural to me. I approached my senior season in June of 2013, and I was 200 pounds. I was exactly where I wanted to be. I felt great, and I was in the best shape of my life. During my last year, my senior year playing football, I'm happy to share that my coach was right when he said I'd be a better player. I earned team captain, offensive line captain, and all conference honors. I also received the Vincent Vincari Award at my school and was nominated for the East versus West football game in New Jersey. The reason why I made this choice to lose weight was all because of football. Honestly, without football, I don't know where I'd be today. Football also helped me get into college. I'll be attending King University in the fall of 2014. And I'll be studying physical education and exercise science. I would love to help eliminate obesity and make our world a more healthier place. Thank you.
Please welcome to the stage the 17th Surgeon General of the United States, Vice Chairman Canyon Ranch, President Canyon Ranch Institute, Distinguished Professor, University of Arizona, Dr. Richard Carmona. Florence Sprague Norman and Laura Smart Norman Professor, Public Health at Harvard School of Public Health, Dr. David R. Williams. Chief Marketing Officer, Jawbone, Travis Bogard. Deputy Chief Medical Officer, American Heart Association, Dr. Eduardo Sanchez. Robert W. Woodruff, Professor and Chair, Rollins School of Public Health, Emory University, Dr. Kenneth Thorpe. President and CEO, Grant Makers in Health, Dr. Faith Mitchell, and Senior Health Policy Advisor, Robert Wood Johnson Foundation, Susan Dentzer.
Good afternoon, ladies and gentlemen. And for Jenna Wolf, if she's still here, I got the best panel. This has been an extraordinary day, and I can tell you one of the things that impressed me most was as Surgeon General of the United States, you realize rapidly that you have a great title, you have a great uniform, but really what you need is a network. You need a distribution network for the content. And as I sat here today in the back and just listened to all of the content, the extraordinary amount of information, the passion by which the speakers, including these youngsters that have come in and showed us all up, who are pretty extraordinary, it brings to mind some of the thoughts I had when I was Surgeon General, and that often what makes us such a great country is the heterogeneity of this country. But the paradox is that sometimes it divides us and creates problems, whether it's with ethnicity or with health issues. But yet, in this room sits the power to really transform not only our nation, but the world as it relates to this pandemic of obesity before us. When I was in office as Surgeon General, I would often get calls, some from you, some of my friends that I haven't seen for a while, and people would say, Rich, why don't you just pass a law? Why don't you just get policy that says obesity is not accepted? And I had many of these great ideas, and I'd say, gee, why didn't I think of that? And of course, the challenge is taking this rich content that you all have, these great, innovative, entrepreneurial ideas, based on science, based on very thoughtful input, and then translating them into a very partisan political environment. That's the challenge as we try and execute and bring this forward. And yet up here, we have truly world leaders who have thought through these things and get things done, because you can't be an effective public health practitioner unless you understand the political process in the city, the county, the state, the region, or the world that you live in, and how timing works, and how legislation works, how policy works. So it is really, really extraordinary. Back in 1998, my predecessor in Surgeon General was a guy named David Satcher, a very dear friend of mine. David put out a Surgeon General's report at that time and said, America, we have to be careful. This obesity epidemic is sneaking up on us, and it will cripple us. It will bury us in debt. It will bury us in disease burden. And of course, when you're competing with 2 wars and a whole lot of other things that the press reports, it's hard to get traction. When I took over from David in 2002, one of the first things we spoke about was the obesity epidemic, and it was a very big part of my portfolio as well, because of all of the things that you know and the reasons you're here today. And today we see that it's eclipsing tobacco as a preventable cause of morbidity and mortality, not only in our nation, but the world. As I travel the world as Surgeon General, often ministers of other countries would say, oh my gosh, what are we going to do? What are you doing in America? From the Middle East to the EU, This is a global problem. And the interesting thing is the rest of the world does watch us. We tend to be the beacon of hope for people all over the world. The solutions that we put into play based on evidence base are often the solutions that you see pop up all around the world. And it's you, the American people, the thoughtfulness, the grassroots that rises up and says, we're going to fix this problem. It's not the government. I've worked on both sides. The government provides support and gives you infrastructure, but it's not the place where you go for innovation and entrepreneurship. It's in this audience where you go for innovation and entrepreneurship in solving these complex problems. And you all are the solution to all of these problems, so I congratulate you for being here. One last comment before I pass it off to David. My portfolio as Surgeon General was very diverse. It included prevention, preparedness, health disparities, health literacy, cultural competence, health diplomacy, global health. Every single bit of every part of every portfolio I had, from prevention to preparedness to health disparities, were permeated by the obesity problem. Prevention is, as you know, the cost, the disease and economic burden is there. But you say preparedness, what does that have to do with obesity? Do you know the number one reason we can't keep young men and women on active duty in our services is obesity? It's amazing. And when I look at national security issues, when I look at the fact that the U.S. Army now has to have a pre-boot camp to get kids healthy enough to even get into the Army, it is a huge problem. It is really metastasized, if you will, all over, and is crippling our nation. And then, of course, health disparities. So as you go across the board on national security issues and preparedness, on health disparities, and even on the global health issues, obesity is at the top of everybody's list as we look at this globally. So this is an opportunity for us to not only make right in our nation and fix our problems, but also really to help the rest of the world who often, desperately now, relies on us to solve these problems. David, please.
It's really good to be here, and I want to begin and echo one of the points you made. We need to put the problem of childhood obesity into a much larger context. I've been working as a staff director for the Robert Wood Johnson Foundation's Commission to Build a Healthy America, and with 16 experts, we have looked across the challenges of America's health. And the news is not good. And that's why we need a wake-up call that we need to rally to do something about the major crisis we face. America ranks near the bottom of the industrialized world on health, and we are losing ground over time. And one of the most striking findings we've come up with is that even the best of Americans today, those with the best health, are not achieving a level of good health that is possible today. So we have a huge problem of disparities, but the biggest disparity is first the national disparity. And just to put the sense of urgency we should approach the disparities problem with, if we just look at the disparities by race, and if we just look at African Americans, 265 black people died today who would not have died if there were no racial disparities in health. Racial disparities in health means the premature death of 265 people each day. Imagine a fully loaded jumbo jet taking off from Newark International Airport and crashing today and crashing tomorrow and crashing every day next week, and every week for the rest of the year, we have that happening every day. What would we do? There is a sense of urgency, I'm saying, we need to approach the challenges we face. The second thing we learned working with the Robert Wood Johnson Foundation's Commission to Build a Healthy America is that we need to start early. These problems, the foundations of health in adulthood, are laid in childhood. And just recently, we had a study come out from the Abecedarian Project. It's a classic randomized controlled trial that randomized children, infants, babies, from birth to 5 into an enhanced preschool program. And they've looked at outcomes now that they are 33. And what they found is that those who received the early preschool program, birth through 5, their weight at age 3 predicts their weight at age 33. And they did a second group where they started the intervention in their first 2 years of school, ages 6 through 8. No effect of the intervention ages 6 through 8. They only find an effect linking childhood outcomes to adult obesity in the birth through 5 age group. just making the powerful importance of starting early. It doesn't mean that we can't do anything later, but the real window of opportunity to have a huge impact is what we do very early. And the other key point I would say that we learned as well is that the problem of obesity and the problem of disparities, the challenge of improving America's health, is not a domain of any sector of society. It's not just the schools. It's not just the healthcare sector. It's not just community leaders. It's about all of us working together. We need to break down the traditional silos of how we approach health and how we approach improving health and work together. And finally, the last point I want to make is that we need to empower individuals. They need to have a sense of ownership of the problem, and they need to bring all of their American creativity together to work together to improve the problem. So we have a challenge. There's a lot that we can do, but we need to inform, engage, empower individuals to take control of obesity in the context of all the other health challenges that we face, because many people who face obesity face multiple other health challenges as well, and we can work together to make a difference to improve the lives of all.
Thank you, David, Travis. And David makes some very good points, especially the connectivity. We've built some great silos with expertise throughout, and we've heard a lot of that today. The real challenge for us now is how do we gain that interconnectivity? How do we address it systemically? And in fact, just about every person I heard either directly said or indirectly talked about how do we link it up, from funding to programs to content. How do we act as one? How do we create a seamless, integrated system that treats this systematically?
So I love the idea that Dr. Risa Mori said this morning, that regardless of our career, we're all public health advocates. And this panel is about what's next. And what I want to sort of share is my view as the technology person here of what we should expect and where this should go. Because I think that where we are today is, I believe, is exciting, because I think the problem that we're talking about here is solvable. And it's not a question of if, it's a question of how fast. Because I think that our expectations need to get to the point that we should be expecting it real time. We should be expecting the ability to solve it very quickly. And so let me explain why I believe that. That ultimately, I think where we've been has been flying blind. We've not had the tools to actually act in real time. When I look earlier at the beginning of the day, we're looking at graphs of how this problem started in the 70s, about 40 years ago. And we even just got data that 2 years ago, things started to look better in some aspects. But the big question for me is, well, what would we have done differently had we seen the impact in real time as sidewalks were coming out of our neighborhoods? How would we have changed after the first neighborhood was built and actually done something differently? Would funding be very different and gone right behind the programs that were working 2 years ago rather than finding out about that 2 years later? So I think that the opportunity and the big question to me is, what did we do yesterday, literally yesterday, May 6th or 7th, whatever day we're in now? What happened yesterday? What can we do today to have impact? And I want the answer tomorrow of did it work? And so let me put that in perspective. Let's say I'm on the industry side and I'm selling sugary beverages into the world. If I run a marketing campaign tomorrow, I'm going to see those sales the very next day. I understand what's working, and I go and double down my investment behind it. We have to get to the place where we're seeing that, and it's actually possible now. So let me give a couple of examples real quick of what we can actually see. So Jawbone, we make a product called Up. It's a band that you wear around your wrist, works in concert with an application and data in the cloud. And those work together as a system to help you track your movement, your sleep throughout the day, what you've eaten, and someone mentioned earlier, mood is a very important part of this. So you can combine all of those, and we're able to use that sensor information to know what's happening. So while it's a tragic example, around the Boston Marathon bombings, what we saw in the area of Boston, people on average lost 19 minutes of sleep that night. The night of the manhunt, within Cambridge and Somerville, people lost an average of 30 minutes of sleep and spent an extra 15 minutes in bed tossing and turning, likely watching the news. And then the night that the suspects were apprehended, they gained 24 minutes of sleep back. So we can see that. We can see that in real time. And you start applying that to public health campaigns. When we phrase it in a certain way, does it work? When we actually put it out there, does it have an impact? And that's what we should start to expect. It's about resetting our expectations now that we have these tools. And that's how we've been thinking about it internally. I literally have our team goaled against improving health. And so as a technology company, we have a public health goal driving in. And so one example of how we're actually taking that and applying it in a tool set is we've been working with the Alliance for a Healthier Generation. And they have a group that serve as role models through the Healthy Schools program. And one of the things that we're helping to do is use the bands to track the activity of the teachers and faculty. Use that as a moment to get everyone excited and get the students involved, cheering the teacher on, and actually in real time with dashboards, seeing how they're doing and how they're progressing, and seeing how they're comparing against one versus the other. So that's just one example of what starts to become possible. I believe it really changes the landscape as we move forward.
Thank you. Go ahead, Eduardo. I'm going to start with a personal reflection. We're talking about children. And I think I'm on safe ground to say that what all of us desire for our children, for our loved ones, for ourselves, for our friends, and those of us who are magnanimous for our enemies, is a good life. And generally speaking, I think we would all agree, a good life in the United States depends on a good job, and I would suggest good health. And generally speaking, in the United States, a good job depends on a good education and good health. So there's some good news. You've probably read that high school graduation rates have improved in the United States. Maybe as high as 80%, but there are disparities. Disparities that you could predict. Latinos, African Americans, American Indian, Alaska Natives, lower than Asians and whites. But there are other disparities that you might predict based on income, based on limited English proficiency, and disabilities. So if any of those describe you, your graduation rates are generally lower than Asians and whites. I work for the American Heart Association. And one of the great things that has happened over about the last 15 years is that the American Heart Association has pivoted and moved from being an organization that's known for being the organization that helped create the science and the skill with which we do CPR, the organization that is about taking care of people who have heart attacks and strokes really, really well and focusing on the medical side. The organization has come to realize we've got to focus upstream. So I'm going to talk about two things. One, we have embraced the creating a culture of health, language and culture. And so the American Heart Association is about how do we do that. One is I'm going to talk a little bit about a framework, the Simple Seven. Simple Seven are the following: no tobacco, healthy eating, physical activity, healthy weight, healthy blood pressure, healthy blood cholesterol, healthy blood glucose. If you are a 50-year-old person and those things are in their ideal state, those seven, the likelihood that you will live to be a healthy and disease-free individual is very, very high. In order to get to that place, got to start young. We've heard from David, got to start as young as, I would argue, before the baby's born. Parents need to be healthy, and mom needs to be healthy, and then we just continue the process. But you got to get there. We've also thought about creating a culture of health in the context of where people live, and understanding that while the Simple Seven may sound like an admonition about personal responsibility, we believe it is important to create the environment in which that is possible. So that includes not only the home environment, the community, schools, the workplace, but also includes an understanding, appreciation, and interest in addressing the social determinants of health. The other place where the American Heart Association has made, I think, a bold move is in stating that it wants to accelerate science. And whereas in the past that science it was and will continue to be about how we do the things I mentioned earlier, do CPR better, do clinical care of cardiovascular diseases and stroke better, It is also beginning to understand that we've got to push in the other direction. And to the point that Travis was making, we want to know what works, why it works, and how we can scale it up. And we want to be a part of the enterprise that will begin creating the evidence base, because the last thing that I think I'll focus on is that we pride ourselves on being an evidence-based organization. So the Heart Association is going to help create the scientific foundation based on analysis of the sorts of things that Travis and others are doing, begin to ask and answer the question of what works, begin to ask and answer the question of what about it worked, and then begin to lay the framework for scaling up and scaling out.
Well, first of all, let me just thank the Clinton Foundation and Robert Wood Johnson Foundation for inviting me. These panels have been outstanding. The speakers have been inspiring. I think it's one of the best several hours I've spent in a long time listening to these speakers today. I think I have a similar message that Eduardo just relayed. I really think in terms of taking it to the next level, we need to do three things. One is that we need to create and keep creating a sense of urgency. If you go back and look at some of the major public health problems that we solved or partially solved, starting with HIV/AIDS, starting with smoking, we had a sense of urgency on both of those once we understood the link between HIV/AIDS and mortality, and certainly when the Surgeon General's report came out, the linkage between smoking and cancer. That created a sense of national urgency to find ways to solve those problems. We need to have the same sense of urgency about the obesity issue, both adult and childhood. It's a somewhat bigger challenge in the sense that, for the most part, obesity is a morbidity issue. Not entirely, but it's a morbidity issue. So it's a harder issue to make traction in, but we need to have a sense of urgency on this issue, just the same way we did with these other major public health problems. So I think that that's one. The second thing I think we need to do is, along the same lines here, is that we've heard a bunch of really good examples of interventions and approaches, whether they be school-based approaches, physical activity approaches, nutritional approaches, and so on, that seem to be effective. We have a lot of good examples. We need to start pulling this together, and pulling it together and really understanding what it is about the design and the interaction among these programs that make them effective. We have a lot of information out there, randomized trials. We have information from practical experiences that we've just heard about. And we know that approaches like, that include school-based approaches that involve the home and community, diet, exercise, nutrition, are approaches that appear to be the most effective. We just need to find ways to understand what are the moving parts there and figure out how best to design those and how make sure that they best interact. We need to scale and replicate these. This goes back to my sense of urgency. We need to find vehicles to take these successful models and make them more widely available. I guess I have somewhat of a concern that as we deal with this obesity issue, we're really moving on two different tracks. We have an adult track and we have a kids track. I think that's a bad way of going. We've identified a lot of very effective adult obesity prevention interventions, programs like the Diabetes Prevention Program being an example. The challenge is that was really focused on adults 20 and above. That program is starting to be widely diffused, flowing through YMCAs, and health plans are starting to cover those services. What about a similar sense of urgency in vehicles for making change for kids? So I think as we think about sort of the third issue, we need to find vehicles. We need to find opportunities, just like we have in the adult world, where the opportunities there are through employment. We have employers, particularly large employers, putting in workplace wellness programs that, if well designed, seem to be very effective. They clearly have an incentive to do this because not only does obesity cost them dollars in terms of medical care, for every dollar they spend on the treatment of chronic disease, they're losing $4 in productivity. So there is a sense of urgency at the workplace. Same thing on the health insurance side. There's a new sense of urgency given the rules under the Affordable Care Act that provide better incentives to keep populations healthy. We need those vehicles for kids. We need to identify where they are. It is somewhat of a challenge. We have over 88,000 elementary schools in this country. And taking them on one by one is probably not a very good strategy. So I would do some thinking about where are opportunities to really take, scale, replicate these programs that are successful, and do it with a little bit more sense of urgency and rapidity. And we do have vehicles. Certainly the governors have a vested stake in this. Employers have a vested stake in this. I mean, we are dealing with the workforce of the future, and if they're not coming into the workforce healthy, they're going to be less productive and more expensive. Coalitions and alliances matter a lot. So I applaud what the foundation has done in terms of their healthier generation. I also run a thing in DC called the Partnership to Fight Chronic Disease that is focusing on the same sets of issues. We have 80 organizations in it, broad-based groups including employers, unions, patient advocacy groups, and so on. We need to find ways to integrate and collectively merge our efforts to really do those three things: the urgency, identifying best practices, finding opportunities for scaling and replicating them, and finding vehicles to do it. So thank you.
Hi, I want to start by saying that Grantmakers in Health is really very honored to be a collaborator in this meeting, which has been months in the planning. I've really enjoyed it today. I hope the rest of you have too. It's been a very stimulating discussion. And for us, it's a chance to engage the health funders that we work with in this important conversation, and also for us as an organization to reach out to all of you. Many of you are not from health, and those are important bridges for us to make with people and organizations outside the health sector. So I want to start by saying kind of who are we and how do we fit into this conversation? There are hundreds of health foundations in this country. Some of them are national, like the Robert Wood Johnson Foundation. Many of them are local. Some of them work in just one city or a couple of cities or a couple of counties or maybe a state, and they operate pretty independently. And that's where Grantmakers in Health comes in. We're the professional association for health philanthropy, and basically we aspire to be like the connective tissue among all of these funders, as well as corporate donors. And our goal is to inform them about issues like this one today, to advise them, and above all, to get them talking to each other so that they can learn from each other. You've heard people talk about scaling, and that's part of what those connections can achieve. Funders can learn from each other and reproduce in their own communities something that has worked in their home community. You can think of these hundreds of foundations as voices for health that are on the ground, and our role is to help them bring those voices together so they are not just individual, but they can speak collectively. You might remember one of the speakers this morning talked about how organizations are working less and less kind of independently, and it's more about networks. And we're a part of that evolution into networks. Childhood obesity is an issue that a lot of health funders care about, and it's an area in which we've been active for many years. The role that we play is we hold meetings, we have publications, we have webinars and things like that. And what we try to do is highlight successes, including in this area, identify the remaining challenges for foundations, and then talk about areas in which philanthropic support can also move policy change to provide families with improved support and engagement related to children's health. So now we're turning our attention, well, we're turning our attention today, but also we've been doing this, to how philanthropy can help with closing the child obesity gap. And one of the ways that we're doing this is we are working with Robert Wood Johnson Foundation and the commission that David mentioned, the Commission to Build a Healthier America, which is the one that uses the Culture of Health framework. With Robert Wood Johnson, we're hosting webinars that will expose funders to the findings of the commission and to encourage them to find ways that they can work on those recommendations in their own communities. So for example, one webinar will be on the importance of investing in early childhood. Another one will look at integrating health into community development to revitalize neighborhoods. And another one will look at bringing a more health-focused approach to healthcare financing and delivery. And the goal of integrating health into community development is one that we're really excited about because it will require health funders to work across sectors. And that's something that GIH has encouraged for years. And as we know, it's not easy to do. We hope to convene a meeting either later this year or early next year that will bring health foundations and community redevelopment and development organizations together in the beginning of a conversation where these two kind of sectors can talk about shared interests and start to think about ways of working together. It reminded me of what Risa said this morning when she said we're all public health champions. We work in different sectors, but we're all ultimately part of the public health picture. We're all working towards a shared goal. Sometimes we don't even know it, but the challenge is just to find ways to do that work together. So just to summarize, what our contribution will be to closing the gap in childhood obesity will be to inform funders about strategies that are working, to help identify the areas where more work is needed, and to encourage new partnerships with organizations outside health philanthropy.
Well, good afternoon. As a senior policy advisor to the Robert Wood Johnson Foundation, it's my job, I think, to summarize some of the themes that we certainly take away from today. And I want to start, though, by thanking the Clinton Foundation and the Clinton Health Matters Initiative for just putting on a superlative conference. Let's please give them a huge, huge hand. And to Grant Makers in Health as well for the support. So in the pantheon of terrific leaders in the nonprofit sector, along with Risa Lavizzo-Mourey and Faith Mitchell and others, is a wonderful gentleman named Bob Ross who runs the California Endowment. And Bob has said, when we think about the need to combat our social problems in this country, innovation, he says, is really overrated. The greatest impediment is our inability to scale up solutions that we know work. And I think what we heard today very much underscores that theme. We heard lots and lots of examples and stories about things that are happening and that are working. And the issue, as some of my colleagues on the panel now have said, is scale. It really is figuring out a way to scale these up much faster and much more broadly around the country. So I will report back to my colleagues at the Foundation a couple of key points as we think about scale. First, it is very clear that what we need right now is the kind of a roadmap that shows not just where the roads are, but where the roads haven't been completed yet. We need a classic gap analysis of what, if we think back to Risa's 6 strategies that the Foundation undertook, we need a gap analysis now to know how far did those 6 strategies get and where. She showed the areas of the country where child obesity rates are stable or dropping. Let's do that. Let's broaden that gap analysis nationwide. Let's really get our arms and our brains around what worked and where have we put in place healthier food in schools, and where have we not done so well, and where have we made real changes in the built environment, and where have we not. We really need that gap analysis before we muster the energy to take this to the next level. So that, I think, is fundamental point number 1, and I will, in fact, go back to the Foundation and urge that we carry out that gap analysis in rather short order. Second big takeaway, and again, this my colleagues have invoked the example of tobacco. We know in this country that it took many, many, many different sets of interventions at many levels to get us from a country where half of adults were smoking to what we have now with about 18% of adults smoking. Extraordinary amount of change in 60 years. We're obviously not done. But what it took was a whole lot more than putting warnings on the cigarette pack. It took lawsuits. It took regulations. It took localities going out in front, taking this on and declaring smoke-free spaces. And little by little, the momentum built to get us to where we are today. And I think since that is our best recent example of a major behavioral change that we undertook as a country, it is the one I think that we have to go back to as we think about the next phase on obesity and child obesity. So what levels do we need to work at? We obviously heard today we need to work in the public sector and the private sector. We have to have the beverage companies in the room. We have to have municipalities in the room, localities in the room. We're going to see change at the local level. We have the example in New York City of the enormous health-related initiatives under the Bloomberg administration. We need to get champions of this around the country to really take up the initiatives at hand. We also need to work across sectors. Clearly that came through, not just public and private, but across even industry sectors. The healthcare sector, frankly, has a big responsibility in this. They were underrepresented today. And we also know we're going to need some initiatives coming out of the lab. Some topics we didn't even really talk about, what we think is the role of the microbiome in obesity. We're going to have to pull lots of people into this conversation. And we're going to have to start doing, and I think Walter Jacobson said this the best, the soft stuff and the hard stuff. The soft stuff is really important. Moms blogging goes a long way. People having the sense of esprit de corps to get out and walk, that goes a long way. But we cannot forget about the hard stuff. The regulations, the lawsuits potentially, the taxes that we may need to exact. We know that we're going to have to chip away at this at multiple levels. So with that, with those very important sets of learnings, I certainly will go back energized from all of the energy in the room that all of you exhibited, and hope that we really can take this to the next level so that when we come back 5 or 10 years from now, we will declare victory on the problem of child obesity, not just the hope that we can persevere and do what all of you are all doing. So thank you very much.
Thank you, Susan, and thank you to all the panel members. You know, we've had quite a day today where Risa opened up and challenged us to build a strong nation through a culture of health, and went over the 6 strategies and a host of other issues there. She pointed out the data, which is cautiously optimistic that the curves seem to be flattening, but also giving us a strong message that we cannot be complacent, that there are still significant challenges before us. Joy Bauer then went with the access to health and food and beverage, and healthy food and beverage, and interestingly enough, other themes kept permeating there too, the need for collaboration, the need for partnerships. I thought it was remarkable that we had Susan and Michael on the same panel and they didn't hit each other or scream at each other, just kidding. But if we can do that, we can go to world peace next, because these are really challenging problems. And you know, many of us are very vested in our own biases of how things should be done. And sometimes, you know, as Pogo said, we meet the enemy and the enemy is us, because we can't look outside of our own silo, or we can't see the other side as possibly an ally in the problem, and we look for enemies. We look for people to blame. We look for people to say it's your fault because of the food you make or such. And really probably bringing everybody under the same tent and having a dialogue and moving forward collectively is going to be the best outcome, you know, for all of us. The issue of directly or indirectly of policy came up, including taxation. Some of these areas are very controversial within the public health and policy community. There's no right or wrong answer, because every one of these policies that we think about has intended and unintended consequences as it relates to the policy that you promulgate, okay? And bringing it into the political environment makes it even tougher. But yet, as Susan alluded to, we have to bring all the people around the table. The right people need to be there, and that's everybody, because this problem belongs to no one sector of society, as David said. This is all of us. We're all parents. We are all people that work in industry. We're all people that work in health and policy. All of us have a part to play. All of us actually have contributed because of our being part of society, as society's changed over the last half a century or so. And then Jenna jumped on board with the opportunities for physical activity, and you know, you hear another theme, cross-cutting strategies, connecting the dots. We have to get together. And for years, I've heard this. You know, as Surgeon General, all these people come to your office and talk to you, and they all have ideas. And the Surgeon General then speaks on these issues. And I often used to joke that I felt like a cemetery caretaker, and that there's a lot of people under me, but nobody was listening. And it really, really tough. But I think we have the right time. We've got the right people here. we have people like the Clinton Foundation and Robert Wood Johnson and grant makers. Everybody's coming together and say, I'm willing to play a part. Let's do it. So, as we move forward now, there's some questions to be answered. Let's talk about what we have done well. And to me, it's like we've really dissected out a lot of the variables as it relates to this obesity thing. Because from a decade ago, David Satcher and I worked together, and then I came in, and people would say, well, why don't you just pass legislation? It was a simple problem, get rid of obesity. But as you dissect obesity, you see it is extraordinarily complex at a macro level and then at a micro level. Because as Susan just alluded to, now we have to start dealing with epigenetics, the human genome, the microbiome. All of those have critical inputs as it relates to the obesity epidemic as well. So that has to be factored in. And then, what have we done well, but where can we improve? What do we need to do to make it better from here on in? What about the role of health literacy and cultural competence? How do we take the best science that the world has ever known, translate it in a culturally competent, health literate manner for an end user who is very diverse to grab it, have it resonate with them to do one thing only: result in effective behavioral change. That's the equation before us to get this all done. But we stumble with health literacy and cultural competence, okay? We have lots of science, but the pipeline of science gets constipated. We don't get it out quick enough, and when we do get it out, it's sometimes not in a manner that that average person can understand. So understanding health literacy and cultural competence. Is everybody at the table of our partnerships and collaborators that need to be there? Is architects, public health people, educators? Are we missing anybody? That's up to you to determine. But everybody that has anything to say that can be transformative should be at the table, even if it's stuff we don't want to hear. Because as has been said many times today, that's probably the people we want to make sure are there. And then, as was said earlier about innovation and entrepreneurship, depending on where you put it in the hierarchy, it may be scale that's most important, but we need to have the innovators. We need to have the entrepreneurs at the table as well. Who are those people? Let's get them on the table as well so we can do things better. So let's open that discussion right now with the team. And who wants to start?
I just want to come back to the issue of disparities and use smoking as an example, because the reductions in smoking is one of the public health successes of the 20th century. But yet almost 1 in 5 American adults still smoke. One, lung cancer is still the #1 cause of cancer death for men and women in the United States, and lung cancer kills more Americans each year than breast cancer, colon cancer, pancreatic cancer, and prostate cancer combined. So it's still a huge problem, and importantly, it is heavily concentrated among persons with low education. So we have been very successful among the most advantaged segments of society, but we have a residual group of core smokers, heavily made up of persons without high levels of education, who are the smokers. Strategies that have worked in general has not worked for that group. And there's a lot of research that shows us that if we just do interventions in general and not pay attention to specific groups and the most vulnerable groups, some of the interventions actually widen disparities. The gaps in smoking in the United States by education are wider today than they were in 1980 or 1960. So we have more disadvantaged people clustering with the problem. So we have to pay attention to what are the strategies that we do, because we don't want to widen the gaps, we want to narrow the gaps, and we want everyone to improve, and we may need some targeted strategies to help those at the bottom of the social hierarchy.
David, those are great points that he makes. Possibly the greatest indicator of health status, educational status, and socioeconomic status are really the drivers, and we see that all the time as you look at those social determinants of health and you look at that at-risk population, and you see, well, gee, they don't have much education. They're poor. They're living on margins of society. And the other thing you brought up now are those that we often forget, the disabled, okay? The disabled are a big population. When I was Surgeon General, we did a report on the health of the disabled. But we chose to call the people not disabled. These are people with different abilities, and they have to be mainstream. But often we forget about them, and yet they have obesity. So when we look at that, it's a drag on society. We miss it. So we can move part of the population up, but some still lags.
So I'll just throw in, I think along the lines of what David was saying, as a nation, and this is a bit broader than just childhood obesity, but I think it comes back to it. We've been willing to talk about the notion of access to health care. We've not engaged in a serious conversation that says every American should have equal access to health. And then what that means. And what that means, I think, back to the issue of disparities, is about access to an equal opportunity to graduate from high school. And if not, then let's address that. And it means equal opportunity to have a good job so that you could have a good life. Let me add one other thing, just for thought. I'm moving to a different topic, but Jim Hill, the 10,000-step guy, James Hill, PhD, researcher, University of Colorado, suggested the following at a talk that I was at, and that is that maybe we need to start talking about health as an input, because oftentimes when we talk about who we need to bring to the table, we frame the conversation our way. And that's not really in the spirit of meeting people where they are. That's in the spirit of bringing people to where we are. But in the spirit of meeting people where they are, health as an input can be framed as the necessary input for good academic performance and the necessary input for a productive workforce. And those may be the ways that we can engage those who sometimes don't think they have anything in common with the challenge of closing the gap in childhood obesity by framing an issue in a way that is their frame, meeting people where they are.
They're really good points. And Ken, in 1 second, just the inputs is a really interesting one, because as we look now at the evolving science, we've been dealing with this problem pretty much at a big macro level. There's some researchers that are dealing with endocrinology. But when we get down to the genome now, and you look at epigenetics, everything we're talking about now could be considered an epigenetic input. Every single thing. Whether it's stress, whether it's behaviors, emotions we talked about today, the foods you eat, the relationships you do or don't have, actually turn those genes on or off and make you less or more susceptible, including obesity. And that's all being worked out now in the Human Genome Project, but yet we know every one of those things are inputs, and they're epigenetic inputs, and they're extraordinarily important. Ken?
Yeah, I agree with what the points that David made. On the other hand, I think that, there is some good news here. We have had some success stories. The reduction in smoking, yes, there are still too many people that smoke, for sure. But if you look at the reduction in smoking over the long term, combined with innovation, statins, antihypertensive medications, we've had a sustained drop over time in cardiovascular mortality. That's very significant. So, we do have some success stories out there that we need to continue to build on. I guess the second point I'd raise is the one that I talked about just real briefly. I do worry that we've really bifurcated this discussion on obesity into adults and kids. And I think that we're moving a little bit faster on the adult side than we are on the kid side, in part because we have more vehicles through employment and through health plans to do it. We have established programs like the DPP, and we have these new class of FDA-approved weight loss medications that have come on the market, targeting really people who are just really extremely obese. We need to have sort of the same set of vision about how we're going to integrate those efforts for families. So I don't want to have on the one hand, I understand we have the separate discussion about kids and childhood obesity, but we have vehicles that are launching right now to deal with workers. Why don't we work with employers to figure out how we can include families into what they're doing with some of these workplace prevention programs and wellness programs and nutrition programs that have proven to be very successful in a lot of firms for adults. This is going to be more successful when we make it a family effort, that we really include not only the adults but the kids, and not only just the kids but also the adults.
We have a question, and I'll take from Twitter right now from Lisa. Faith, you want to address that one?
Yeah, I wanted to kick off the response. The question is, what is one policy or program that has not been able to be implemented and you believe could really help reduce health disparities? One of the themes that resonated with me today was the number of people who talked about the importance of engaging families and communities in this work and how hard it is to do that. And Nicole Maher from the Northwest Health Foundation saying the importance in particular of getting communities of color at the table as part of the discussion. And we don't do a really good job of that. I think some speaking from the perspective of funders, some have been better than others. Some have worked with community organizations that do a better job than others. But there's a lot of work that needs to be done in that respect, and I think that it is one of the major barriers to dealing with health disparities, because until you get those voices kind of represented, parents, communities, you are just doing to people, as Eduardo said. You're not kind of reaching people where they are. You are coming up with something that you think is going to work and then trying to implement it without necessarily even being appropriate.
Your point's very well taken, and really it speaks to the social network. I mean, because haven't heard it today, but there's a term of obesity being contagious. That's about a social network and who you associate with, okay? And so I think it brings greater importance in bringing the family. We heard it more than one time today also about who's our patient, who's the agent, what's the relationship? We don't have enough children here. A lot of the children need to be there as well. Often it's us adults that are meeting to say what the children should do, but their perception of what they need is different, and that could be a significant driver as well as to whether they utilize something or not. If they own it and they love it, they're probably going to be, as been demonstrated earlier. Susan?
Richard, I was going to say a policy or program that is being implemented that gives us a real opportunity now is coverage expansion under the Affordable Care Act, particularly because, as we know, preventive services now are covered at no out-of-pocket cost to the consumer for everybody. One of the pieces that is not yet clear, though, is where weight loss advice and weight loss programs fit into that equation. Number one. And number two, the other thing that we know is that someone today earlier said obesity should be viewed as a clinical problem. It's obviously more than just a clinical problem, but we also know we don't have enough clinicians who feel comfortable yet often broaching the subject of weight with certain of their patients and populations. So we got to get them on board, understanding that should be part of a prevention and wellness visit, that kind of counseling, directing people to effective evidence-based weight loss programs, or even, I'll just tell one short story. Years ago, when I was at the PBS NewsHour, I went to cover a fair where people were treating the uninsured, donating medical services for the uninsured. And I met a man there who had once weighed 350 pounds. He used to have to weigh himself on a grain elevator. And one of the physicians who treated him for free one year said, "You're going to die. You just got to go out and get yourself a dog." And by golly, he went out and got himself a dog and just walked the heck out of that dog. He told me, I interviewed him, he said, "I love that dog more than I love my wife." You know, even simple interventions, the diabetes prevention program, you know, which again is basically modest amount of weight loss, it makes a huge difference. But it's back to this point of getting all the players at the table, the clinical community, take advantage of the provisions in the Affordable Care Act, maybe expand them, drive the evidence so that we get these services covered, and make as much headway as we can with that piece of the set of interventions.
Go ahead, Travis.
I wanted to add on, touch on the social aspect that you were talking about, the fact that obesity could be contagious. We saw that idea and said, we think health could be contagious in the other direction.
Yes.
And one of the things when we built our product, we did right from the beginning, we built social into the experience, that I could be connected to people around me and I could start to see how they were doing. I could comment on that. I could start to dialogue. And what we've found is people who have friends in the system, on average, move 10 miles more a month and do 20% more in duration and quantity workouts. So it has an impact and it is working, yes. That social aspect. And so, you know, I think that plays a big role in terms of, you know, how does this continue to scale?
Right. And I think one thing, and then we get to Eduardo, it plays into the emotional side too, because we know that people are disconnected from their social network, who are depressed, tend to eat more, and tend to get involved in sedentary activities. So when you're connected, in fact, there's plenty of information now through functional MRI as well as looking at neurotransmitters that all of those go up. Serotonin goes up, oxytocin goes up when you have those relationships, which keeps you engaged and not eating. So there's a lot of physiologic and even, you know, as I said, epigenetic inputs that we're not even appreciated yet at a genetic level that are driving this as well.
That's exactly right. One of the things that the way that system works is, and literally we call it the feature dopamine response, yes. Which basically when someone someone, you see someone's activity, you can just do a quick happy face.
Yes.
And it's not a negative the other direction, it's empathy.
Absolutely.
And so having that relationship at a very feeling level is very important.
Yeah. Eduardo.
In terms of the previous question about one thing that, a policy that maybe isn't being replicated enough or not adequately implemented, I think there's a compelling body of evidence that shows that there are a fair number of coordinated school health programs in this country that are working, and that are working in communities that you might predict would be challenging environments to either hold down or even reverse obesity. And the challenge isn't knowing that the program works and that you have a policy that says there ought to be coordinated school health. It's the funding issue. And so the good news is that the Affordable Care Act may provide more resources for more, but we also have to think about how we work within that funding opportunity to push the idea of where the dollars go to the child equivalents of the Diabetes Prevention Project, which could be schools, could be the YMCA, could be a number of settings. But we've got to figure out it's not just scaling up by doing it everywhere, it's how do you pay to do it everywhere.
Eduardo, you know, it's a good point you make, but I would even go beyond the pay. When I think of the 3 young people that we heard speak today, and I look at them, to me, they're promotoras, okay? These are health promoters. They may be in high school or just starting college, but in fact, in their communities, they probably have more impact in their social network than we do. By the fact that the young man who lost 100 pounds and now he's a scholar athlete, or, you know, all the 3 that we heard today, they have compelling stories and they network. So the literature is very clear, not in obesity yet, but if you look across the board at asthma and underserved communities, you look at a lot of other diseases, and you'll see that maternal child mortality. You take a 17 or 18-year-old girl and you teach her about that, and she goes door to door and makes sure every young lady in the neighborhood gets multivitamin, folic acid, gets prenatal care, has good nutrition. All of a sudden, you see a plummet in birth defects, okay, and problems. And it's the same thing we could do here. So when I saw those 3 young people who were so gifted, and quite frankly, I don't think I could have walked out at the stage at their age and how poised they were. I mean, think of the impact that people like that have in the community. And I listened earlier to the school nurse who was pleading that we need more school nurses. Absolutely, we do. I've spoken to I'm a former registered nurse myself. I went to the American Nurses Association. I've spoken to the School Nurses Association. There's not enough nurses. But with nurses supervising promotores in the community, you can do something innovative that actually helps to move this forward as well. Ken?
Yeah, again, I think Eduardo raised an important point here because he just talked about the history of public health. And it's a sad history. If you look at the preventable mortality, preventable morbidity, 60, 70, 80% of it is due to potentially preventable public health interventions. We only spend about 3% of our healthcare dollar on public health and prevention. So as I think about this, this isn't going to organically flow through a public health network, unfortunately. And as much money as our great funders here have, and they've been really out in front of helping to move this ahead, we know that that's not going to be sufficient. So if we're going to really scale these things up, we've got to, it's the old Willie Sutton thing, we've got to go where the money is. And for better or for worse, the money and the opportunities are really through health plans, that we do have the opportunity, I think, through the Affordable Care Act, and it's through employers. Those are the big money vehicles that provide, I think, the best opportunities to really integrate population and public health into the mainstream of more traditional medical care.
Quick comment, and then let's get some questions. So who's out there wants a question? Ken, that's just an extraordinarily important point. But I think that right now we should also reinforce the fact that every single provider of any kind needs to become a public health practitioner. We've heard it over and over. I know Eduardo and I have said it for years that we've been in government, you said it and such. I mean, the surgeon who sees an obese patient sees the obese patient as a threat to his surgery, but doesn't address the obesity issue other than the anesthesiologist marks that person with a higher risk profile for surgery, and they send them home obese. I mean, you think about all of the interactions, the paramedic, the EMTs, the pharmacist, all of them have to be bought in, to be public health providers. And because pharmacists see far more patients than any of us on a daily basis, why aren't they in the network and at the table as well? And just recently I met with the American Pharmacists Association. They're very interested in having an expanded scope of practice and being involved in public health initiatives like this. So it's being smarter, being innovative, and maximally utilizing the resources we have. Question, please.
Hello, my name's Kate Brashares. I'm the Executive Director of Edible Schoolyard, New York City. And I've been reflecting on some of the things that you've been saying about who's at the table. And one of the groups that I've noticed has not really been represented at the table today is the food industry, particularly, you know, thinking about processed food and that industry. And it also struck me in relation to the analogy that some people have made today about tobacco and the public health fight about tobacco. And my question is, how can we make sure that we engage that group, which is such a powerful voice in this crisis, in a positive way and in a way that really engages and draws that very, very powerful group into the conversation?
Okay. Anybody want to start? Or you want? Let me just start real quickly, and I'll just give an anecdote, and then I'll pass it to my colleagues. When I first came into office in 2002, one of the first things I was challenged with when the White House called was to say, by the way, there's a lot of lawsuits that are going to be filed now against the food industry for making America fat. And I was like, oh my God. And so cabinet members and the president are saying, well, so what are we going to do? And it was a critical juncture because everybody wanted to jump on board and blame somebody. But to your point, I took a chance, and I got foresight, checked it through my chain of command, but I went to McDonald's. I went to Coca-Cola, and I sat down and started a dialogue. And the dialogue was after spending a day at the Hamburger University in Chicago, and I learned how they do things. I met their dietitians. I met all of their scientists. And then I started asking questions. So once the CEO, who at the time was Mike Roberts, got to know me and saw that I wasn't there to undermine or accuse him, the first thing I said to him was, Mike, I need help. I'm the doctor of the nation. I have this obesity problem. I'm not blaming you, but you market your product better than I market my product. Can you help me learn how to do better to sell health? And we started this dialogue. And then he introduced me to Coca-Cola, which is the partner they have for beverages. And I had the same conversation there. And over a 1.5 year period, we asked, can you make the fries a little different, maybe change that oil? I was sensitive to the need to make a profit and to have a business, but he was sensitive to my needs to help America get healthy. And I asked questions. I said, that's supersized. Do we really need that anymore? You notice quietly it went away. Okay, there wasn't any fanfare. Nobody blamed anybody. They looked at it. They did away. Kids' meal, fruit, yogurt, maybe a piece of broiled chicken. That's all just conversation. So it can happen if you engage and have a relationship. It's not easy because they're not used to the public health community reaching out. And there's still controversy. But those are the things, the collaborations we need to get everybody in, including the food manufacturers, as you said. Other comments?
I would just add, I agree with you about the importance of having the food manufacturers, and these are wonderful examples of how we can work effectively with them. I would say another important group missing is the media. We are going to build a culture of health. We need to get the major forces that drive the larger national culture so that we can get some of the action coming from the ground up where people, because they've been influenced by the media and the media elites, are now thinking about health much more concertedly than they've done in the past. So that's another group that we need to work with effectively if we will make the healthy choice the easy choice.
Now let me make a quick point. I'm going to use Travis. David, you're absolutely right. The challenge, of course, is that public health has never been sexy, okay? Body counts draw the media, the war draws the media, and I learned that when I was SG. And it wasn't until at a press conference one day when a reporter, we were in a bioterrorism conference about early warning things, and she said to me, so Surgeon General, what is your biggest problem? And I said, obesity. And they all looked at me like I was smoking something. And she said, why? I said, obesity is the terror within. And that was a national headline. And I realized that science doesn't sell for science itself. You have to figure out how to spin it so it does get a headline, and then people ask you more questions. So you're absolutely right. I think we just have to be better at spinning what we know so that it does attract the attention.
And Travis, the last panel had some good ideas about social media and how we can use it.
Absolutely.
And that we need to build on those ideas.
Absolutely. I think you touched on something really important, which is it really does come down to finding people who can go solve your problems for you and finding who's best at solving that. One of the things that's most exciting to me around what we've done is that at the end of the day, we're doing behavior change. We see it, we know it's happening. We don't market it that way because no consumer's buying that. But at the end of the day, the same things that we're doing are the same things that corporate wellness programs pushed out, and they failed to get engagement in a lot of places. Consumers are walking into an Apple store or in a Best Buy and AT&T, spending their own post-tax dollars without reimbursement yet for it, and they're basically saying, I want this for myself. To me, that's how you get to there, is you go and find the people who can say, this is how the problem, I'm having difficulty getting this education in front of someone. And so we take some of that information around, let's say, why is sleep important? And we put it in front of someone right at the moment where they've just had less than 6 hours sleep and say, this is why it's important and why you should start to care. And it's not just one of us out there solving it. We're all part of a puzzle that we need to piece together, and each of us are going to have a strength in that. And so it's finding the people who can do that best.
Your point, it's a good point, and I think it underscores this whole concept of health literacy. If we can empower the people to understand, they will demand healthier things. Look in the food industry now. One of the fastest growing areas are farmers markets. They're popping up all over the place. And that's because there's a demand. People want to get healthier food. They want it from the farm to the table, and they don't want all the intermediaries that put the bad stuff in. So I think health literacy becomes very important. We have another Facebook question here from Ashley. What do you think the philanthropy community can do differently to double down efforts in addressing health disparities? Go ahead, Faith. Why don't you start?
Yeah, I was giving that some thought. Well, for one thing, more of them can get engaged in the issue. Because if you think about it, there's probably not a community in the country that doesn't experience health disparities. But the reality is that foundations have to make decisions. They can't do everything, and so they have to set priorities. Some have set health disparities as a priority, some don't. In my mind, that's where data can come to help reinforce the argument for doing more, like the numbers that David was talking about. And that's where GIH can come in, where we just say, the problem is far from solved. This is what's happening. Some gaps are widening. You can be a part of solving this problem. And then that's where lifting up what's working comes into play. And there are things that are working. Mm-hmm. So it is, I think, ultimately it's an awareness and then engagement and understanding that when we talk about disparities, we're talking about lifelong health issues, things that start when people are babies and that affect their health for the rest of their lives.
So just quick, Susan, I want Susan to comment on a policy issue here because, our worlds all revolve around 2, 4, and 6-year election cycles. Yet we all realize that the problems that we are addressing today are intergenerational transfers of information that will take us decades to get there. And moving effective policy when we live in that 2, 4, and 6-year cycle is an impediment, quite frankly, for public health, because public health doesn't change that rapidly. And you and Ken especially have been in the forefront of policy as it relates to that. Can you comment on that, Susan, as far as the barrier and how we might engage our audience to think about that? Because many of them haven't had that relationship at the political level, especially at the national level.
Again, I think the example of smoking is instructive because you didn't get universal movement all along the levels of policy for 60 years by any stretch. It was 1 step forward and 2 steps back for a long time. And as we know, the major action-forcing event in the last 20 years was the lawsuits filed by the state's attorneys general against the tobacco companies, and it was only then the federal lawsuit came into being. So the states ended up, in a way, taking the lead on the last big wave of it. And I think we'll probably see something similar here. And I guess just to tie it back to the earlier conversation, I really hope we can get to where we need to go by inviting the food companies into the tent and having the nice conversations. But I don't think you can leave out the notion that there may have to be some pretty powerful lawsuits, because we just heard from Walter Jacobson what happened when the Grocery Manufacturers Association didn't want a major piece of regulation through. So, a lot of these folks are willing to fight very long and very hard to protect their turf and their profits, and you can't dispense with the notion that there may have to be some real tough steps taken. Again, I think to the degree that we can basically hold up the champions of people making real steps at the local level, like the New York Cities of the world, like Austin, Texas, which has done an enormous amount with the community, what used to be named the Community Transformation Grants, and healthier food in schools, hold up, shine the light on communities, and basically create a kind of a competition among localities. How come they're doing it and we're not? And then build from there, have the same thing happen at the state level, and then sooner or later the feds will also get on board as we get real examples of things that have worked.
Well, clearly to be successful, we all have to be health diplomats to be able to move this through a very complex environment. Another question from the audience, please.
Hi, Dr. Glenn McCullum. I'm here on behalf of the Academy of Nutrition and Dietetics, and I really have a systems question for the panel, and that is, when we're looking at being part of this important change, and we've seen it coming for years, I think there's also perhaps two other groups that are missing around this dialogue table, and that would be one, in the medical community of looking at how do we change the mindset to a prevention mindset. And then secondly, I know we all talk about education and training those in our communities that help support this type of change, but I don't see the interdisciplinary, for example, my background, nutrition. Nutrition plays a very important role, as does physical activity, but in our medical community, even still yet, very little is done in training nutrition and physical activity, both for our physicians as well as even our nurses. And I would say we all want to be part of the solution, but how do we bring about maybe those two challenging system changes with this important, because it does impact childhood obesity as well as adulthood obesity.
Thank you, Jen. Ken, you want to start? And then
Yeah,
Eduardo?
I think some of it goes back to, so I resided in an academic medical center. So we have a nursing school, we have public health, we have a medical school, and so on. And if you think about it, every one of those people being trained are going to deal with a diabetic or a hypertensive patient and so on, but in their own domain. We don't have any integrated teaching that really looks at the whole span of prevention, management, treatment, and so on. So I think in part it starts with medical schools and academic medical centers. If we don't train people to collaborate and work together, they're not going to collaborate and work together. So that's a part of the history of how we've done the training. I think that there are opportunities here, though, and there's some good examples out there. I was talking to Susan about this at lunch. In Vermont, they put together interdisciplinary community health teams that deal everything from population health, prevention, low-income energy assistance, all the way through the medical management. And those teams are nurses, nurse practitioners, social workers, mental health workers, pharmacists that work with physician practices and so on. And I think one of the good pieces of good news is that the American Medical Association, to give you a specific example, is working with the YMCAs to figure out how they can increase referral rates from physician practices into programs like the diabetes prevention program and other types of preventive programs. So I think that there's some movement there, but we really do have to figure out how we're going to broaden our focus on the healthcare side from just insurance to really population health and more traditional medical care.
So let me see if I can be quick. One, even in the research arena, there's that need for interdisciplinary and a systems approach. And the American Heart Association actually is in round 2 of what they're calling focused research networks, which are putting out calls for proposals that require basic science, clinical science, and population science perspectives in the proposals that are brought forward from different entities, in fact, thus promoting and expecting collaboration and sort of a systems approach to thinking about these problems. Second, in terms of the treatment, the Heart Association, along with the American College of Cardiology, has put out guidelines on lifestyle interventions and guidelines on obesity treatment. Those represent multidisciplinary approaches and multidisciplinary input in developing those guidelines. We need to go further so that guidelines for how you do it are not just about they're patient-centric, so it's about the team approach to taking care of the issue, childhood obesity or whatever it may be. And I would add one more thing. We need to teach docs and everyone else on the health team how to advocate outside of the walls of where they practice to address the conditions that are affecting the health and livelihood of their patients.
Let's take a final a Twitter question here, which is, health and childhood obesity have become polarizing political issues, you think? How do we depoliticize this?
I would just say, I think we have to look at one small note of optimism. If you look at a state like Mississippi, where we have seen real gains in child obesity, people seem to be willing to get their brains around the notion that we have some responsibility for our children. Mm-hmm. And you can't look at what Mississippi has done and not conclude that that's really became the dominant political feeling in the state. Now, by the same token, they also turned around and passed a law barring any locality in the state from implementing any kind of Bloomberg-type legislation, banning sodas and so forth at restaurants. So I think the issue is more around children versus adults. I think we can build on a sense of solidarity around children, just the way we did, for example, when we enacted the Children's Health Insurance Program back in the late 1990s. So let's look at the optimistic side. If we can just get people on board with doing this for our children, maybe we can decide that we want to do it for adults too.
That's a good point, Susan. You know, when I look at the stigma associated with obesity, it reminds me of mental health as well in our country. And then when we look at the mental health population, which is a vulnerable population, we see obesity problematic there as well because it's a marginalized population. And until we can embrace these problems without the stigma, it makes it extraordinarily difficult to address them. Faith?
To me, it's, you know, building on what Susan said, it is a we're all in this together kind of message, because it's ultimately about productivity. You know, people have said a sick workforce is not an effective workforce. Sick kids don't become healthy workers without some kind of intervention. And you also have the military issues that people were bringing up. You can't even have an effective fighting force if you have kids that are unfit, you know, to serve. So that, to me, it's like reminding people, yes, these issues may be politicized now, but there's another way of looking at them, which is, as I said, we're all in this together. We all have something to benefit from improving children's health, for sure. Children are usually an easier lift than adults, and we all have something to lose if the trends don't change.
We just have a very few minutes left. I know the panelists will be in the reception also for any of you who have additional questions, but I would like to ask each of you just to give a take-home message to our audience. What is it that we should do? How do we get better at what we're doing? How do we come together? Whatever you choose, but let's give a take-home message here that sums up all of the content we got today and how we can get to the next level. You want to start, Dave? Put you on the spot. Professor?
No problem. I would begin just by saying I think one of the things this day illustrates is that there are a lot of solutions out there. And we need to talk about the problem, but I think what helps people the most is giving them examples of solutions. And the way this program was structured, seeing young people and what they have been able to do, and seeing the range of solutions, let's focus on solutions. Let's give people tools so they can make a difference and take control of their life and destiny and our future.
Travis, very good.
I think the system point was actually a great one, which is, you know, there's a saying in traditional healthcare, I don't exist until I file a claim. You know, that's impossible to get to prevention and actually focusing on health if we don't solve that. And so I think thinking about the system, thinking about how we can educate people around how they're sleeping, how they're moving around, and connect that into the system and into those dialogues on a daily basis, I think is very important to solving this problem.
Thanks. Eduardo?
Maybe overly simplistic, but we need to collect the data that informs. We need to convene the partners that can make a difference. We need to converse about what we want to do, and then we need to carry out our plan. I'm not sure we're doing that as comprehensively as we ought to, and that ought to be part of our goal.
Okay. Well, I think we need to have a quick transition from one that's focusing on pilots to one that's focusing on implementing things that we know that work. So it's a common theme. We're not one pilot program away from a miracle, all right? We have a large accumulated body of evidence on things that we know that work. So I think the challenge here is just understanding the moving parts, the design, what are the key elements of them, and then find places where we can do rapid adoption of them. And that's where the money is. And again, this is the history of public health in this, is that we're not even 4th or 5th in line. We're like 10th in line. So if we're going to really be effective here on the obesity side across the board, we really have to find the financing channels to make it sustainable, to take those effective interventions and make them sustainable over the long haul. And I think two of the best opportunities really are through health insurance, public and private, as well as employers working with communities and working with faith-based organizations and communities at the same time.
I'd say, taking our cue from tobacco, let's stay in this for the long term. We're not going to make changes overnight.
Everything that has just been said, and shine the brightest possible light on the successes and feature the faces that we saw today, the Kianas, the Andrews, the Haleys. People will resonate to the stories of other people, so we can't tell those stories and have those people tell their own stories enough.
I agree, and in closing, I would say it's been said already, but I think all of us need to impart a sense of urgency to everything that has been said here today, because this is an urgent problem, whether you look at disease or economic burden. And one of the most important things, and I give credit to all of the sponsors that are listed there, and Ginny Ehrlich and her team from the Clinton Foundation, is conventions like this of thought leaders are so robust and bring these ideas together. And really, it shortens the timeline. It shortens that pipeline to get something done. Now is the time that we need to take all of this, and I know Ginny's going to get this information out, but then we have to get to execution. I mean, what is it we're going to do? We've got enough, as I said, I used to tell my team, we certainly have enough research in the pipeline, but the pipeline's constipated. How do we get it out? How do we get it out in a culturally competent, health literate manner to evoke sustainable behavioral change, which is what we're looking for in all of the populations we have the privilege to serve. But in this room is the brain power to do that. I mean, today I have been so empowered just listening to and listening to the personal stories, listening to the anecdotes. We have the ability to do this. Now we have to continue to express that sense of urgency to allow us to do that and allow this to permeate our communities so that we can approach optimal health and wellness. Thank you all very much, and thank you to the panelists.